Yeah. A 46-year-old man on oral hypoglycemics attended his regular diabetic clinic. Random blood glucose done at the clinic was 5.6 millimole per liter. HbA1c was 12.9%. Estimated average glucose 18 millimoles per liter. Calculate which of the following is correct. So let's start with analyzing this person's lab results. Is the random blood glucose in the normal range, or is it low, or is it high? Yeah, it's within the normal range. The normal range is usually 3.2 to 7.8. So we can see that this person's random blood glucose is in the normal range. And what does the HbA1c do? What does it monitor? What is it used to show? Yeah, it's long-term control, like over 3 months. Yes. So it shows the glucose regulation over a long time, like 3 months. So this one, 4 to 6% is usually pre-diabetic, 5.7 to 6.4. 4 to 6% is the normal range. Then pre-diabetes is 5.7 to 6.4%. And then diabetes mellitus when it's more than or equal to 6.5. So we can see that this person's is above 6.5. So it's a diabetic condition. So let's start eliminate. What's the answer here, guys? What do you think is the answer? It's A. The patient is not compliant to the medications. As we can see, the random blood glucose is in the normal range. So, but the HbA1c, the 3 months control shows that it's high. So this person is not compliant to the medications. They can neither see if he's taking them regularly or they should change the medication. Then let's rule out the others. The patient is experiencing an acute illness, not necessarily. Acute illness would be, no, it's not this one. The dose of medications should be reduced. No, it shouldn't be reduced because as you can see, the long-term sugar is not controlled properly. The patient is at risk of getting, why is RBS normal? Nate, can you help me? It's from, besides the fact that it's between 3.2 to 7.8, I don't think I can give a reason why the values are differing. Nate, can you help me?
Yeah, I'm seeing someone saying a suggestion on the chat where could it be that he took the oral medication that very day to lower the glucose?
That could also be possible.
Yeah, that
So,
can be
because
possible.
he knew he was going for a regular checkup, so maybe he knew and took the medicine that day. But if this person wasn't taking medication as directed by the physician, that would show the HbA1c that's high. But the daily, if that, yes, I think I'll go with the medication that very day. Thank you. Number 3, what do you guys think is the answer? B, yes. In the first days of neonatal life, one reason for indirect hyperbilirubinemia is the immature liver enzyme. So this person the baby doesn't have enough glucuronil transferase, so they'll end up having increased bilirubin, which will cause the jaundice, the neonatal jaundice. And they usually give they expose these babies to phototherapy. That's the remedy for that. Yeah. And the UGT, this glucuronyl transferase, is involved in bilirubin conjugation. It conjugates the bilirubin which was from the breakdown of the red blood cells. Then it can be unconjugated and then excreted. So this baby does not have enough or matured enzymes, the glucuronyl transferase, so they'll not convert the bilirubin to, and they'll not conjugate, like metabolize the bilirubin. So that's why they'll have jaundice. Does anyone have a question? Okay, let's continue. The enzyme responsible, number 4, what do you think is the enzyme responsible for delipidation of lipoprotein by removal of triglycerides is? Yes, LPL is B. It's lipoprotein lipase. Lipoprotein lipase. It in the lipoprotein, it removes, lipase means ase is the nini for breaking down, so it breaks down the lipoprotein, removes the lipase one nini, and then it causes triglycerides, so it's LPL. The next question is number 10. Oh, you've answered this question. Number 10, I answered it. Let's just answer it. Ovarian tumors associated with formations of psammoma bodies. It's who can tell us the answer? C. Yeah, it's serous carcinomas. The serous carcinoma of the ovary. So there's a mnemonic for tumors associated with psammoma bodies. I'll send the mnemonic. The mnemonic is psammoma, like this word psammoma. So papillary carcinoma of the thyroid, serous papillary cystadenoma, papillary carcinoma of the ovary, meningioma, papillary renal carcinoma. I'll send the mnemonic in the group, in the WhatsApp group. We continue. And then we go to question 12. Who can albumin to creatinine ratio ACR done for a 42-year-old female type 2 diabetic showed an ACR of 8,990 milligrams albumin per gram of creatinine. Which of the following is correct? A, the test should be done only in patients with type 1 diabetes. B, dipstick urinalysis will show ketonuria. C, the result is in keeping with microalbuminuria. D, the result rules out a UTI, a urinary tract infection. E, the result may be due to pre-analytical error if she is having menstrual bleeding. What do you guys think is the answer here? Let me just, I haven't seen any answer in the chat, so let's just answer this. So let's first, the albumin to creatinine ratio, this ratio is done to assess kidney function. That's why it's done. So usually it assesses the amount of albumin in urine. So less than 30 is normal. A value less than 30 is normal. 30 to 300 classifies as microalbuminuria. We have little amounts of albumin in urine, so microalbuminuria. Above 300 is usually classified as macroalbuminuria. Then usually when people have between 30 to 300, that's microalbuminuria. And that one, there's other non-related causes, like causes that are unrelated to kidney function, like acute hyperglycemia, UTIs, marked hypertension, congestive heart failure, and menses. Menses can give a false positive. So let's go back to our question. A. A says the test should only be done in patients with type 1 diabetes. This is wrong. It's usually a result of all people with diabetes, like type 1 and type 2, should be done for this test, because diabetes that's not controlled will lead to diabetic nephropathy. So, and the diabetic nephropathy is like a severe, extreme end of diabetes. So, uncontrolled diabetes, either type 1 or type 2, will lead to diabetic nephropathy. So, it should not only be done for patients with type 1. Also, it can be done with people to assess cardiac function, cardiac mobility and mortality. Like, it's also a marker of cardiac mobility and mortality in people with this type 1 and type 2 diabetes. So A is wrong. Dipstick urinalysis will show ketonuria. Let's start this one. The result is in keeping with microalbuminuria. As we have seen, it's above 30, it's above 300, way above 300, so it's not in keeping with microalbuminuria. The results rule out a UTI, not necessarily, but we'd have to do another, like, my UTI is usually within 30 to 300, so it's like we can rule it out, but we can also do a UTI test to like rule out the UTI properly. The result may be due to a pre-analytical error if she's having menstrual bleeding. The pre-analytical error can be increased. Like, you can see that from between 300 and 8,000 is a very big number. So I canceled out this one because 8,990 is so much for it to be a pre-analytical error because of menstrual bleeding. So I went with B, because the reasoning behind B was that this person has the kidney function of this person is not okay. Like, so this person will probably not have the kidney will not be in the greatest condition to secrete protein, like to absorb and secrete proteins and other solutes properly. So this person is most likely to be found with ketonuria. Yeah, so the answer I went with was B. Someone has asked, kindly recap on the, so microalbuminuria, no, this ACR ratio is used to assess kidney function. For less than 30 is normal, so 0 to 30 is under the normal range. 30 to 300 is classified as microalbuminuria. And then in this microalbuminuria, we have other causes that could cause microalbuminuria that are not poor kidney function, like acute hyperglycemia, UTI, urinary tract infections, UTIs, marked hypertension, congestive heart failure, and menses. So these ones will show, menses will show a false positive, but the others, yeah. Is that okay? Have you caught them? Okay, so we go to number 14. Have you done this question? Okay. You've done 14. Okay. Okay. We go to number 16. Have you done 16? Okay. So we'll go to number 24. Have you done 24? Okay. The okay. Num Dipstick urinalysis of a 76-year-old man whose specimen had a deep amber appearance showed only bilirubin to be present, and the rest were nil. Which of the following is correct? I went with what is the answer to this one, guys? Yeah, I also went with A. The patient has obstructive jaundice. Should we go through the jaundice thingy, or you guys have gone through that? Well, let's just go through it. So, red blood cells, after 120 days, they're broken down into globin and heme. Heme is broken down into the iron part goes back, then to the iron part dissociates from the heme part. So we have protoporphyrin. Protoporphyrin is converted to unconjugated bilirubin, which is this one we were talking about in the neonate. This one is the one which caused jaundice, because that kid did not have the glucuronil transferase which conjugates this bilirubin and makes it conjugated bilirubin. So this UBC, this unconjugated bilirubin, is in the blood. So it's carried by albumin to the liver. And in the liver, we have the conjugation into conjugated bilirubin. Then it's stored in the gallbladder as bile. So from here, it's released as bile. So we have three types of jaundice: prehepatic, hepatic, and posthepatic. I'll share with you. May I remember to share all this? I'll share with you some. Let me clip it right now so that I remember. Yeah. So for obstructive jaundice, that means obstructive jaundice is usually posthepatic. That means the gallbladder is like we have a constriction, the bile is not going out properly. So that will cause increased bilirubin, as we've already conjugated it, but it can't be out to be released as staco. Let me give me a second. As stacobilin in the feces or urobilin in the urine. So this bilirubin will increase, and it's the one which will associate with this man's increased bilirubin in the urine. So, and then, so are we together? Why it's the nini? Let's go through the other types. Oh, that's wasting time. Should I just go through the answers, or I go through the other types of jaundice? Okay. So we've seen we have prehepatic, hepatic, and posthepatic. So in prehepatic, it's from excess production of bilirubin. So we have excess red blood cells lysis. So it's usually a result of like autoimmune diseases, hemolytic disease of the newborn, rhesus incompatibility. So it will cause increased production of this. It's prehepatic. It happens before this unconjugated bilirubin reaches the liver. So we'll have increased plasma bilirubin. Do we understand why? Yes, are we together, or like, can someone just shoot a text to say for it? Okay, so thank you very much. So like, because we are from heme, protoporphyrin, then unconjugated bilirubin, this is prehepatic. We are producing so much unconjugated bilirubin than the liver can process and conjugate. So we'll have increased unconjugated bilirubin. So the urine is free. The urine is free from urobilin. Then stool color is usually darker than normal due to excessive stacobilin formation. We've seen that the bilirubin usually becomes stacobilin or urobilin. Yeah. So the stool is very, very, very dark because of the extra bilirubin that's being released. So we go to the hepatic. This one causes hyperbilirubinemia due to impaired uptake of bilirubin into hepatic cells. Now, and then or disturbed intracellular protein binding or conjugation. So if we cannot conjugate this bilirubin properly, we're going to have its increased levels, or disturbed active secretion of bilirubin into the bile canaliculi. So the causes may be due to damage of liver cells, autoimmune hepatitis, yeah. And then we have, so the both conjugated and unconjugated are present in blood. So in plasma, we have both conjugated and unconjugated. And then the urine becomes dark brown due to the excess conjugated bilirubin going through. And the stool is usually pale grayish due to deficiency of stacobilin. And then the posthepatic is usually due to obstruction of the biliary tree, intrahepatic bile duct obstruction, or extrahepatic bile duct obstruction, like gallstones, cancer of the head of the pancreas. Intrahepatic can be drugs, primary biliary cirrhosis, or cholangitis. And then the conjugated bilirubin formed cannot pass into the small intestines, and it returns back to blood because we've constricted the outlet of that bilirubin, so it's going to go back in the blood. And then, so which is why this guy's bilirubin was high. So usually in prehepatic, so we're going to, can we be unmuting to go through this together? So as we've explained, we're going to go through, let's first do prehepatic, then hepatic, then posthepatic. So in prehepatic, what do you think is the level of unconjugated bilirubin? Is it increased or normal or decreased? In prehepatic, we're talking about unconjugated. Is it increased, decreased, or normal? It's high. It's high because, like, yeah, the formation of, yeah, very correct. And then we have, and how about the conjugated bilirubin? Is it increased, decreased, or normal? I'll help with this one. This one is usually normal. And then the AST and ALT, the transferases, aspartate transferase, alanine transferase, are normal. Then ALP, alkaline phosphatase, and alpha GT, alpha glutamyl transpeptidase, they're usually normal. Then urine bilirubin is absent. Urine urobilinogen is present, and the stool stacobilin is darker, like is increased. So let's go to posthepatic because this is the case that we're doing here. So for this one, posthepatic unconjugated, do you think unconjugated is normal or decreased or increased for posthepatic for this patient that we're doing? For posthepatic, is unconjugated bilirubin increased, decreased, or normal? Remember, the posthepatic, we have a problem at the level of the biliary tree. So everything above from unconjugated to conjugated is okay. But now the problem is this conjugated is not stored in the gallbladder because we have an obstruction. So the unconjugated will be normal because it's not affected. The blood is broken down and conjugated is conjugated, but now the conjugated cannot be stored, so it's going to increase. What increases is the conjugated one. And then AST and ALT are normal. ALP and alpha glutamyl transpeptidase are increased. So we go to this question. So we'll eliminate option B. The transaminases are likely to be higher than alkaline phosphatase. And we've seen that the transferases are usually normal, but the alkaline phosphatase is increased and the alpha GT. they're the ones that are increased. I'll send a chat. It will all make sense. I'll send a chat in the group. Yeah. So the patient is likely to have hypercalcemia, not necessarily. There's nothing in these findings that point to hypercalcemia. The patient has a predominant indirect hyperbilirubinemia. As we have seen, they have high bilirubin, but it's not indirect, it's direct. It's from the blockage of it's from obstruction of the biliary tree. Estimation of serum CA125 is useful for the management of this protein, of this patient. No, because what tumor is serum CA125 indicative for? Yeah, ovarian tumors. So there's no need to, it's not useful in the management of this patient. Yeah, okay. So we go to number 25. Decreased pH in a patient specimen cannot be considered an ideal marker because it is A, dependent on biological variation, B, prevalent in virtually all patients, C, not measurable easily, D, indicated in more than one disease manifestation, E, a metabolic function. What's the, yes, it's D, yes, indicated in more than one disease manifestation. Yeah. So we go to number, this one is straightforward. Should we go through it? Yeah, it's just D. We go to question 42. 42. The, yes, yes, it's D. The greatest buffering capacity at physiologic pH would be provided by a protein rich in which of the following amino acids? It's D. The histidine is the best buffer at physiologic pH. The side chain of histidine has a pKa of 6. The maximum buffer capacity occurs at pH which is equal to pKa. And this one is the only one whose pKa is almost around the one for the body. So it's D. We go to question 53. This one, what's the answer? E. Yeah. So C-reactive protein, it's an acute phase protein. I felt let's just mention other acute phase proteins. I'll just give you a list. We have CRP, we have complement proteins, haptoglobulin, fibrinogen, and serum amyloid A. Yes, haptoglobulin. Yeah. Yeah. Thank you, Nasra. Let's go to the next question. Number 74. What's the answer to this one? A 26-year-old lady presented to your clinic for pregnancy test. What specimen would be appropriate? Yeah, it's E. It's E. It's the random urine. Next is 79. A 44-year-old man was presented in your clinic suspected of poison ingestion. Your query is methanol or ethylene glycol. What tests would you request for? What's the answer to this one? Yes, it's E. Yeah, it's the osmolality and osmolar gap. Yes. Uh-huh. These are the primary tests for everyone for anyone who you suspect has a methanol or ethylene glycol test or ethylene glycol poisoning. Then you can do other supporting tests like electrolytes, creatinine, and some liver tests. Number 87. Do you guys should we explain that? Yeah, 87. So on this question, a fluid deprivation test was ordered for a 45-year-old female. Which of the following is correct? What do you guys think? E. Yeah, it's E. So let's go through everything. A fluid deprivation E is correct. So they did a fluid deprivation test. So this test involves denying a person of fluid for 10 hours. So naturally, the body will tend to conserve the water by passing small amounts of concentrated urine. It will pass small amounts of urine and it will be very concentrated. But it's usually used for people with diabetes to test for people with diabetes insipidus. So people who have diabetes insipidus, we know that they usually have polydipsia. So they'll continue passing large amounts of urine that's even dilute, and there'll be an increase. So we're removing a lot of fluid. So we'll increase plasma osmolarity, and will be passing out large dilute urine. So the second part of this test, like a normal an individual, a healthy individual will reduce the amounts of urine and it will be more concentrated. But people with diabetes insipidus, throughout these 10 hours, they'll continue passing large amounts of urine and it will be dilute. So we'll have increased plasma osmolarity. So in the second part of this test, they give this person synthetic ADH, and ADH is used to reabsorb the water. So if they have central diabetes insipidus, the problem will be corrected and they'll start like releasing less amounts of urine, which is less dilute. It will correct everything that had been done. But for a person who has a nephrogenic diabetes insipidus, ADH administration will not, there'll be no improvement. The person will still continue releasing large amounts of dilute urine. So, yeah, let's go through the options. The first part of the test was depriving the person of fluid for 10 hours. So the condition may be due to a disorder in the loop of Henle, not necessarily, because the loop of Henle is usually involved in reabsorption of solutes. And here we're mostly looking at water, the reabsorption of the solvent, like water. The affected hormone is a steroid hormone. No, it's not a steroid hormone. The affected hormone is ADH, and it's a peptide hormone, so B is wrong. Increasing urine osmolality during the fluid deprivation excludes a hypothalamic disorder. Not necessarily. This one, let's start it. The test is indicated for patients with syndrome of inappropriate ADH secretion. This one, usually people with SIDH have increased secretion of ADH. So usually for them, the fluid deprivation test is not necessarily done. And these people have decreased serum osmolality and increased urine osmolarity, which is contrary to this person who has diabetes insipidus. And it's usually SADH. I found it worthy to note that it's the hallmark for SADH is hyponatremia with hypoosmolarity and high urine osmolarity. Because this person is like releasing a lot of like water. So in the serum will be more concentrated, there'll be more solute because we're losing most water, and the urine will be more will sorry. People with SIDH will tend to absorb a lot of water, so there'll be more water in the body, and the urine will be very, very concentrated, which means high urine osmolarity. And because we're absorbing a lot of water, we'll have decreased serum osmolarity because we have more fluid in the body than the solute. And I went with E, administration of synthetic ADH as part of the test, as we have seen. The first part of the test was for people with diabetes. We deny this person of a fluid. So a normal person will have less urine, yes, less urine output that's more concentrated, like the person in SIDH. But for people with diabetes insipidus, for whom this test is usually done, they'll have more dilute urine. The urine still is a lot. They still have polydipsia and it's dilute. The urine is dilute. So they have decreased plasma osmolality. Yeah, so the answer is E. Have we understood that one? Guys, do you have any question? Yep. We go to 91. A 34-year-old male was admitted in a coma. Analysis of the arterial blood gave the following values. PCO2 16. It's low. The reference is 35 to 45. Hydrogen bicarbon, HCO3 is 5, so it's low. pH 7.1, low, so that's acidosis. And who can classify this metabolic derangement? This derangement, sorry, acid-base disorder. Yes, it's metabolic acidosis. So this one is partially compensated metabolic acidosis. So let's in metabolic, we've said metabolic acidosis because when the pH is low, like lower than 7.35, that will be acidic. So we have acidity. So here we're going to say metabolic because the metabolic is so low, and the lowness in PCO2 is due to compensation of this metabolic acidosis. So in metabolic acidosis, a person tends to have more hydrogen ions in the body. So the rate and depth of respiration is increased. They'll hyperventilate. So this will reduce the PCO2, which is why it's kind of like this reduction of PCO2 is a compensatory mechanism of the body. And then in metabolic acidosis, we have an ion gap metabolic acidosis and an anion gap metabolic acidosis. There's a mnemonic I usually use for metabolic acidosis. It's LADDER, LADDER. So L is for lactic acidosis, the causes of metabolic acidosis now, because we've established that it's metabolic acidosis. So L is lactic acidosis. A is acetazolamide use. D is DKA, diabetic ketoacidosis. The second D is diarrhea. E is ethanol or methanol. And then R is renal tubular acidosis. So this one is for the generally. So yeah. So I went with, what would we say is the answer here? Number 91. A. Yeah, it's A. Um, Monique. I usually use LADA. LADA. L is for lactic acidosis. And then A is for acetazolamide use. D is for the first D, or you can, D is for diabetic ketoacidosis. Then the other D is diarrhea. And then E is ethanol or methanol. And then R is renal tubular acidosis. And then for non, okay, I think, okay, now I might, okay. So there's usually questions for clean chem that have, they even give you an anion gap. So the other mnemonic, as you can see, these ones are scrambled up, is for metabolic acidosis as a whole. It's if we had like DKA, this, no, if we had another one and an anion gap, they tell you to calculate it. For the non-anion gap, it's Dr. A, diarrhea, renal tubular acidosis, and acetazolamide use. Those are the non-anion gap metabolic acidosis causes. Dr. A. So in the ladder, Dr. A, diarrhea, renal tubular acidosis, and acetazolamide use are the non-anion gap. So from the two thingies, you can always work out the anion gap. Okay, we go to the next question. Okay. Number 96. All are true for renal handling of acids in metabolic acidosis except, what do we think is the answer here? A, hydrogen ion secretion is increased. B, urinary acidity is increased. C, renal glutaminase activity is increased. D, bicarbonate reabsorption is decreased. E, urinary ammonia is increased. What do we think is the answer here? Yeah, it's D. So let's go through the Nene. So we've established that metabolic acidosis will have a lot of bicarbonate being accumulating in the body, which is what is causing the acidosis. Metabolic is usually accumulation of bicarbonate. Then the respiratory is accumulation of carbon dioxide. So hydrogen ion secretion is increased, yes, because we have to we have acidosis means like we have more hydrogen ions. So hydrogen ions need to be removed. Urinary acidity is increased. So as we increase the hydrogen secretion, there are more in the urine. So we are making, start this one and then we'll come back to it. Renal glutaminase activity is increased. The renal glutaminase usually is used in the metabolism of glutamine, and this helps generate bicarbonate ions, which are used to buffer the excess acid. Like we are releasing a lot of hydrogen, so this glutaminase is going to be involved in the metabolism of glutamine, and then we release HCO3 bicarbonate. So H3O C plus this one, they'll form the H2CO3, which will be released. And since we are increasing this bicarbonate excretion, the urinary acidity is going to be increased because it's going to tend to be more basic. Do we understand why? Guys, has that point been understood? Okay, as I wait for an answer, bicarbonate reabsorption is decreased. We need to buffer the excess hydrogens in the body, so we have to reduce the bicarbonate. We have to increase. Urinary ammonia is increased. This one is correct because the kidneys will increase production and excretion of ammonia, which combines with the hydrogen ions that we are releasing to form ammonia. So urinary ammonia is increased. So I went with D. I repeat C. But renal glutaminase activity is increased. So the glutaminase is used in the metabolism of glutamine. The whole metabolism will generate bicarbonate ions, which will be used to buffer the excess hydrogen ions that are being secreted in A. So because we're having a lot of hydrogen ions, we release also, this glutaminase is going to act a lot so that it metabolizes glutamine, releases extra bicarbonate ions, and then they buffer the extra hydrogen that's being released. Are we together on this question? Mm-hmm. Okay, we can just go to the next question. 97, Nate. So someone told us that this question, it was an error. Yeah, 4 were false negative. They said it was supposed to be 3. So true positives are usually sensitivity tests how many positives did you get that were truly positive. It tastes how positive, like it tastes the positive. So we'll just use positive. So the formula for sensitivity is true positives over true positives plus false negatives. So the question is, 70 people were tested for a disease. 9 were true positive, 31 were false positive, 26 were true negative, and 4 were false negative. What is the sensitivity for this test? So someone, they corrected us to correct this 4 to 3. Yeah, it's A, it's 75%. So we're going to get 9 over 4 over 9 plus 3, because these false negatives were also positive. So it's did I say the formula? True positives over true positives plus false negatives. So it's going to be 75%. So the answer is A. Uh-huh. Next, is 129. Okay, 129. Intrinsic causes of AKI include the following. What do we think the answer to this one is? I think we'll first go through them. So intrinsic causes of acute kidney injury. Acute kidney injuries has causes that can be divided into 3: renal, pre-renal, renal, and post-renal. So in the pre-renal, we have hepatorenal syndrome, which is B, ACE inhibitors, D, hypotension, atherosclerosis, sepsis, and acute pancreatitis, C and D. So from B, C, D, and E, these are pre-renal. And then intrinsic causes mean like intrinsic inside the kidney, so they're renal. So we have acute glomerulonephritis, then we have nephrotoxicity, which paracetamol poisoning causes nephrotoxicity. And then we have tubulointerstitial nephritis. And we have postrenal causes, which can be intrarenal or extrarenal. The intrarenal can be calcium urate casts, and then extrarenal calculi, neoplasms, yeah, anticholinesterases. So in this answer, we can see that the A is the answer, paracetamol poisoning. We've seen that B to E are prerenal, and then A is correct because it causes nephrotoxicity, which is a cause of renal or intrinsic acute kidney injury. And then we go to question 135. The pH of body fluids is, I'm sorry. The pH of body fluids is stabilized by buffer systems. Which of the following compounds is the most effective buffer system at physiological pH? It's A. It's A, bicarbonate buffer. And then we go to question. I think that's all, guys. I think that's all. Do you guys have any questions? Who states that the girl has been drinking a lot, so she has polydipsia. So we think maybe uncontrolled blood sugars. Physical examination reveals a young girl whose eyes protrude slightly. Further workup reveals the presence of multiple lytic bone lesions involving her calvarium and the base of her skull. What is the most likely diagnosis for this girl? What's the answer? Yeah, it's C. Um, oh, you guys have already done this. Let me just do the. Okay. Let me just mention it because I had done it. This is a Langerhans cell histiocytosis, but it's not unifocal. It's multifocal. Together with, it's a combination of this multifocal and the involvement of the posterior pituitary, and it's usually okay. So it's a Langerhans cell histiocytosis. It's usually characterized by hyperproliferation of Langerhans cells with eosinophils, lymphocytes, plasma cells, and neutrophils. So we have Langerhans cells, they proliferate, and then the unifocal are most common. They most commonly affect the skeletal system. So people with unifocal lesions will tend to have. Give me a second. People with A will tend to have it's more like it mostly affects the skeletal system. So, and then multifocal, it's usually a bone disease, affects young children, and then they present with multiple erosive bony masses, which expand to adjacent soft tissue. So, the involvement now of the posterior pituitary stalk, which equates to the base of the skull, leads to diabetes insipidus in almost all people, which will account for the polydipsia this baby had, this small child had. So the combination of the calvario bone defects, diabetes insipidus, which is the extrusion of the eyes, is referred to as the Hand-Schüller-Christian disease. I just wanted to mention that. Yeah. And then someone told me to repeat the anion and non-anion gap acidosis. What is it? The anion gap, for metabolic acidosis, the metabolic acidosis, the whole mnemonic is LADA. LADA. So lactic acidosis, acetazolamide use, diabetic ketoacidosis, diarrhea, ethanol and methanol overuse, then renotubular acidosis. Yeah. So for the, give me a second. For the anion gap, I usually like they're all over the place. So I have a mnemonic for the non-anion gap, because if you know all of them, which is LADA and non-anion gap, you can always work out the anion gap. So non-anion gap, the non-anion gap, it's Dr. A, D-R-A. It's Dr. A. D is for diarrhea, not diabetic ketoacidosis, diarrhea. R is for renotubular acidosis, and A is for acetazolamide use. So whenever you see a question where you're supposed to calculate the anion gap and they ask you the causes, so I think that comes in handy. Yeah. Thank you so much, guys, and all the best in your revision. Yeah, you got this.